Good afternoon. My name is Cindy Shireman, and I am a Community Engagement Specialist for Mayo Clinic Health System in Southwest Wisconsin. Welcome to our community forum, COVID-19, What's New and What's Next? The COVID-19 pandemic has challenged our lives in ways never thought possible, and in many ways, we will never be the same. As the pressure of a pandemic begins to recede, we ask ourselves, what does it mean to move from pandemic to endemic? Are we there yet? What will this new life be like? And what's next? Today, our presenters will work to answer those questions and to provide you with the most current, reliable information to help you navigate this new normal. We've received many questions from our registered attendees, and you can continue to submit questions throughout the forum using the Zoom Q&A function. We are fortunate to have 4 experts sharing their knowledge with us this afternoon. Our panelists include Dr. Gregory Poland, is Director of the Mayo Clinic Vaccine Research Center. He's a leading voice on the scientific evidence supporting the benefits of COVID-19 vaccines. Dr. Poland is also editor-in-chief of the peer-reviewed medical journal Vaccine. He has chaired or served on federal committees involved in vaccine decision-making, including the National Vaccine Advisory Committee and the Advisory Committee on Immunization Practice. He's regularly featured in national news stories and is in high demand as an advisor and speaker. Caroline Poland is a licensed mental health counselor and certified clinical trauma specialist. She is founder and CEO of Poland and Associates Consulting and is founder and owner of Landmark Counseling Center at Taylor University. She has published numerous scientific papers and book chapters incorporating cognitive models into health decision-making, specifically looking at vaccine hesitancy and acceptance. She has presented at many invited seminars and national and international talks. She is also, as you may have guessed, the daughter of Dr. Poland. Dr. Raj Palraj is a Mayo Clinic infectious disease specialist and a member of our Southwest Wisconsin team. He has also been on the front line of COVID-19 since the pandemic began and has been featured in numerous regional news stories. Finally, Dr. Paul Mueller has served as Regional Vice President for Mayo Clinic Health System in Southwest Wisconsin since 2018. He is a professor of medicine and a professor of biomedical ethics in the Mayo Clinic College of Medicine and Science. And now we will turn it over to Dr. Mueller to begin today's program.
Well, thank you, everyone. We're delighted that you're with us today. My understanding is that we have about 700 registrants for this important forum. And if past experience informs us, there will be thousands of you watching on social media. So we appreciate your attention to this important topic and the issues, as Cindy outlined, that are relevant to us today. This first slide gives you a snapshot of how things have really changed in our nation over the last several months related to the pandemic. You see the red United States in January, and that was during the peak of the Omicron surge. And I can tell you, even here in La Crosse, we had upwards to 40% of patients being tested for COVID were in fact positive. Our hospitals were busy. Our staff were busy, and we dealt with that surge. And correspondingly, hospitalizations and deaths were high during that time. Then 2 months later, you see the green. And what that really means is that the amount of community spread, including in Southwest Wisconsin, is pretty small. In fact, we've had days here in La Crosse, several days where we had 0 positive tests. So what does this mean? We're hearing a lot more about variants. We just got news today about the Moderna vaccine in children from age 6 months to 5 being efficacious. We're hearing about the term endemic. What does this all mean? Next slide. just to get you up to date, and this data is freely available on the cdc.gov site. It actually is from yesterday, not 11 January, so I apologize for that error. To date, there have been 80 million cases. There's probably more than that people who had COVID infection, in fact, were tested. We're approaching 1 million deaths, and 83% of people age 5+ have had at least one vaccine. Omicron and its subvariants account for most cases, and that's that bar graph on the right lower corner. You see most of that's purple or a purple color, that's Omicron. The orange you see is the former Delta variant. Cases, hospitalizations, and deaths are dropping. You see the far right-hand side of the daily deaths graph on the upper right, and we're seeing that number really drop. Yet, nonetheless, unvaccinated persons have higher risk for hospitalization and higher risk for death. So what to do? We're seeing changes in public health recommendations. Health systems are relaxing their visitor policies. Do we still need to socially distance? Do we still need to mask? What about kids under age 5? What does the new Moderna announcement mean for vaccines? What about boosters? Do we get a fourth booster or a second booster after your initial 2 series? And as many of you know, oral treatments are on the horizon. When will those treatments be widely available? Are they effective? And then finally, what does it mean to be in an endemic versus pandemic? So next slide. So we have an AllStar Cast today, Dr. Poland and his daughter Caroline and Dr. Raj, who will help us answer some of those questions. And I'm going to turn it over to Dr. Poland.
Thank you so much, Paul. And again, thank you for asking me to participate in this. Just a couple of things. First, to start, let's see, how do I advance? There we go. I give consultative advice to basically all of the Western vaccine manufacturers. The situation is a very interesting one. This is a novel hypermutable virus that rapidly changes. I think you all understand that. We have very highly kinetic and dynamic data, coupled with often irrational human behavior, a good dose of uncertainty, periodic surge-related morbidity and mortality, as Dr. Mueller was just explaining. And so I think we should always consider that our conclusions are conditional and to some degree tentative. The reality of it is that everything we understand about SARS-CoV-2 is conditional upon time, variant, geography, type of host immunity, host factors and individual and collective behaviors, population structure and levels of immunity, including the community burden of transmission, and the interplay among the above. For those that of you have seen the movie, you'll get the reference when I say, welcome to the Matrix. Well, the real brutal reality, again, as Dr. Mueller alluded to, has been the unfathomable number of deaths. We are bearing down on 1 million Americans who have died in the last 2 years, directly attributable to COVID-19. Over 120,000 deaths due to Omicron alone. Well, that calculates out to about 1 out of every 328 Americans dead. We're having about, let's call it 1,000 people a day die, and we're pretending that the pandemic is over. I tell you that if we had 100 cases of polio a day, which rarely results in death, we would be in an absolute panic. But we have become normalized or accustomed to this. Right now, only 65% or so of Americans are fully vaccinated, and less than 40% are fully vaccinated and boosted. And so it's no surprise when you look at the percent of the population that has had a booster dose. Other than Japan, we are far below other highly developed countries. And unfortunately, the consequence of that is not surprising. We have more deaths per capita than any other middle or highly developed country because of our human behaviors. And as a result, you've seen things like this. It varies by month a bit, but in terms of average daily cases, it's about threefold higher in the unvaccinated, and average daily deaths about tenfold higher in people who are not vaccinated. But trying to get that information across has been nearly impossible for the residual population that is not vaccinated. And so they continue to fuel the hospitalizations, the deaths, the complications. Dr. Mueller mentioned the BA2 or so-called stealth Omicron. This has really arisen very rapidly, and it began right as non-pharmaceutical interventions were relaxed. It's about 50 to 60% more transmissible than Omicron was, with some evidence of increased immune evasion, somewhat reduced efficacy of our monoclonal antibodies. And for pre-exposure monoclonal antibody, you actually have to double the dose as a result of this. In the US, it's now overall about 25% of all new cases. However, some of the genetic sequencing services are saying they believe it may be more like 60+%. This is doubling about every week since we decided to pretend that the pandemic is over. In the Northeast corridor, it's now about 40% of new cases and about 30% in the West Southwest. Case numbers in New York City have risen 40% in the last 2 weeks. Europe has generally been ahead of us and are a good bellwether for what's going to happen here. They've had a 35% increase in hospitalization rates. So let me talk about some of the myth conceptions about vaccine. There are three enemies here: increasing age, increasing comorbidities, variants, and time. Because whether you have illness-induced or vaccine-induced antibody or immunity, it does wane over time. So when we think about boosters, this is the concept that we as vaccinologists carry in our head. At the beginning of a pandemic, of course, nobody's immune. We want to build immunity quickly. We were prevented from doing that by human behavior collectively. For those that do get immunized or those who got infected, their immunity wanes with time. So you have to boost. And you continue that cycle. You're familiar with this. We do this every winter with influenza. And at some point, the virus changes sufficiently that you have to refocus immunity to a variant-focused booster. Now, one of the myth conceptions is vaccine efficacy. This is a decreasing gradient of protection. Like nearly all of our vaccines, it is far better at disease blocking than it is at infection blocking. So if you look at prevention or efficacy against death, it's in the 90s. Same with severe disease, hospitalization in the 80+ range. You get down to mild disease and asymptomatic infection, far less. So if we look at just some recent examples, and these are 12 to 17-year-olds, and they're looking at the efficacy in the effectiveness in preventing an emergency department or urgent care visit. And you see that if you got 2 doses, by 150 days, it's down to 45%, falling to essentially no protection against mild to moderate infection after 150 days. If we look at the Omicron predominant time period, same thing. But notice what happens when you get your booster dose. It goes back up to 80%. The same is true over here with people who got 3 doses, and this is prevention against hospitalization, up at the 88th percentile. So boosters work, no question about that. Similarly, if we look at hospitalizations among older adults, if they got an mRNA vaccine, you see the efficacy wane with time. And then if you get 3 doses down here, it boosts up from 54% to about 90%. If we look at invasive mechanical ventilation or in-hospital death, again, 3 doses up at 94%. So this is eminently boostable and effective. So vaccine safety, I'm going to fly over this. Wisdom resides in understanding that no human-made product is 100% effective nor 100% safe. And so the nexus of wisdom lies in understanding the balance of risks and benefits, because one of 2 outcomes will happen. You will either get infected, you will get vaccinated, or both. There is no avoiding one of those states unless you go into absolute isolation, and that has its own set of risks. So let's look at something like myocarditis. Myocarditis generally results, if in hospital, a 1-day or so hospitalization treated with a non-steroidal drug. Rare to have any long-term sequelae. So if we give 1 million young men, 16 to 17 years old, a dose of the vaccine, we can expect about 70 myocarditis cases, but we prevent almost 57,000 cases of COVID, 500 hospitalizations, and 170 ICU admissions. So I always say to people, pick which risk you want. There is no zero risk here. You can have this risk, or you can have these risks. So if we look at the number of excess events due to exposure per million, this is what happens if you get SARS-CoV-2. This is your risk of myocarditis compared to the risk with a vaccine. Pericarditis, same thing, almost no cases due to the vaccine. There are some. Cardiac arrhythmia, very small number due to the vaccine, large number due to the disease itself. If we look at infected versus uninfected, the risk of myocarditis is 16-fold higher if you get infected with COVID-19. So is Omicron the path to endemicity? Let me just say that when we talk about endemic disease, that does not define a number that I can tell you. Rather, it refers to a somewhat vague concept of baseline rates of disease. That is, rates that normally we can't reduce. So is this going to be our path to endemicity? There is no way to know. When you hear people saying, yep, this is the end of it, they are speaking out of ignorance, frankly. We do not understand the biologic, virologic, and immunologic rules by which viruses become endemic. We do know that high levels of immunity do have a forcing action toward endemicity. At this point, SARS-CoV-2 cannot be eradicated. There are a number of reasons for this, but as I have told the media, because of the way we have handled this, our great, and go as far as you want, grandchildren will be getting COVID vaccines or dying of COVID or having complications as a result of infection. And we're seeing this whether we look at wastewater, whether we look now at a very well-established animal reservoir, which is why we cannot eradicate it, continuing emergence of variants. And now what we're beginning to understand is the considerable follow-on health effects, even people who have mild COVID. A paper out this morning showing about 40% higher risk of developing diabetes or having to go on oral agents to decrease blood glucose. Well, the physician philosopher Marcel Sandrel said, each civilization by its customs, its laws, its principles of thought, creates for itself a pathology appropriate to itself. A society chooses its diseases and shapes its pathological destiny. And in my opinion, we have seen that in full living color in regards to the United States and SARS-CoV-2. And with that, I will end. Thank you.
So now we'll turn it over to Caroline Poland. No questions at this time for Dr. Poland.
Well, it's wonderful to be with you all today and to be talking about this topic and really to begin to talk about the mental health pandemic that has come alongside this COVID-19 pandemic. A brief disclaimer here, this presentation provides just general information. It's not meant to be specific advice to any individual situation. Well, the reality is that our body and our mind are connected. We are whole people. And so our areas of health are interrelated. And we really can't have discussions about physical health while also ignoring mental health. Our physical health and our mental and emotional health are intertwined. The reality is that we are now in year 3 of a global psychological trauma, and we do not come away from trauma unscathed. And trauma isn't just in our emotions or in our head, but rather trauma is stored in our body. Trauma impacts our brain chemistry, our nervous system, and our overall health and well-being. And we will walk away from this pandemic with scars, grief and loss, anxiety, depression, addictions, and trauma. So let's begin by framing what the problem actually is. Well, the WHO report that was published earlier this month indicates a 25% increase in anxiety and depression worldwide in the first year of this pandemic, according to researchers at the University of Pennsylvania as of November 2021. So this stat does not take into account our recent Omicron wave. 1 in 450 children in the United States has lost a parent or a caregiver to COVID. A recent report published looked at the fact that there are higher risks of PTSD in individuals and their families after COVID ICU hospitalization. We know that substance use and other addictions have increased in times of chaos and uncertainty where we feel unstabilized. Humans tend to go back to the coping skills that we know work, that are easy, that allow us to numb out or shut down. We have the impacts of long-haul COVID on mental health, the impacts of chronic illness on our mental health, and looking at that in the long term. And then, of course, we have continuing waves and potential other variants of this pandemic that creates stress and uncertainty. So you can see that we're beginning to piece together some of these mental health aspects of this pandemic. But here are some mental health implications of COVID. Again, these are just scratching the surface, but these are some potential signs to look for within mental health. Difficulty concentrating, focusing, poor sleep, nightmares, increased anxiety, hypervigilance, stress across multiple areas of life, irrational decision-making, loneliness, going into shutdown or depression. Like I said, you can trigger other prior experiences, suicidal ideation, suicide attempts, and a variety of other issues. Well, on March 8th of this year, The Atlantic published an article that they entitled, "How Did This Many Deaths Become Normal?" The reality is that we're nearing 1 million deaths. And to quote this article, roughly 9 million people, or 3% of the population, now have a permanent hole in their world that was once filled by a parent, child, sibling, spouse, or grandparent. And that doesn't speak to the friends and the colleagues left behind with the death of COVID as well. The reality is that we have normalized death without normalizing treatment for the results of this pandemic. So what's the solution? I think a lot of this comes to reframing and prioritizing. We need to move to a place where we can normalize the reality of the effects and impacts of a pandemic that has impacted over 2 years of our lives, with no certainty of when this will end or how this will end, or what an endemic will really look like. We need to work to reframe reactions and responses to the pandemic and the trauma that has been endured as the normal responses to an abnormal set of situations. Instead of pathologizing people's responses and reactions to this pandemic, we can normalize that, of course, these things happen when we have gone through this set of situations. We need to prioritize funding for mental health services and support in each vector of life. And we need to prioritize organizational health and healthy workplace expectations to help mitigate burnout and secondary trauma, especially in the healthcare profession. We all have mental health, just like we all have physical health. And just as we need to be both proactive and reactive about our physical health, it is important to be proactive and reactive about our mental health as well. And yet, because of the stigma that mental health still holds, because we are not prioritizing that, because we have not reframed that, we do not treat mental health in the way that we do physical health. I want to highlight that, of course, focusing on mental health or seeing a counselor isn't a failure. And in fact, it is a sign of strength and courage when we are willing to face the hard and traumatic things in our life. When we're looking at mental health, again, we're looking at how to be both proactive and reactive. And one of the ways that we can be proactive is not only to address our historical trauma, to help to heal our mind and our body, but also to build in protective barriers around our mental health that help to widen our window of tolerance, that zone or range that we're optimally functioning in, and to increase our overall resiliency. These are a few ways that we can engage in some of these basic self-care strategies that provide some of this protective barrier. Of course, functional exercise and body-based movement. When we hit moments where we go into hyper arousal, where we get angry or anxious and hypervigilant, a surge of cortisol and adrenaline is released in our body. And if we don't do something to complete that stress response cycle, we stay in that highly activated, anxious, stressed out state. And that takes a toll not only on our mental health, but also on our physical health and our overall immune functioning. So we need to make sure that we're moving to help to close that stress response cycle. Of course, restorative sleep habits, healthy foods, getting outside in nature, regular engagement in nature. The color green has been shown to really improve our overall mental health. It helps to reduce anxiety and depression. Implementing a regular practice of gratitude is an important protective barrier for our mental health. And I do want to mention here that gratitude is not meant to deny the hard and painful realities of our life. When we're talking about gratitude, we're not talking about toxic positivity or trying to force positivity. In some ways, for some individuals, toxic positivity or forcing positivity actually works in a way opposite than we want it to, and actually increases anxiety and depression. So gratitude really works to widen our reality to the both and in our life, the hard and the good, instead of either or. So I created a simple tool as a way of improving self-care, and it is simply head, heart, body, a way to balance out our overall well-being and provide some of these protective barriers. With head, we're looking at decreasing the use of cognitive distortions or just these habitual ways of thinking, which can increase anxiety and depression, such as all or nothing thinking or catastrophizing. With our heart, we're looking at connecting to our emotions, being aware of what we're feeling so we can engage in appropriate self-compassion or emotional regulation. And we're also looking at connecting to others. We are not islands, and we need to be in good connection with others to help mitigate impacts of loneliness. And with our heart as well, we're looking at engaging in counseling services. And then with our body, engaging in good physical health rhythms like we just talked about. Again, we're just scratching the surface today. I do want to mention I have a YouTube channel, Pullen and Associates Consulting. You can go in right now and hit subscribe. And there are a number of different playlists here that I have full of information on mental health and COVID. And some of what we talked about today is here in this bottom set of playlists. And if you have further questions, you can find my email address and website here. Thank you.
Thank you very much for that informative presentation. We'll move on to Dr. Raj Palraj.
Thank you and good afternoon, everyone, for joining us. Next slide, please. So I'm going to kind of give a brief update on the treatment options that we have in the outpatient setting. We have two oral options that people can get, and there are also two IV options that patients who are not sick enough to be in the hospital, but who have mild to moderate infection, and they can get treatment. Next slide. The first drug is from Pfizer. It's called Paxlovid. It's a combination of two drugs. One is ritonavir, which is a protease inhibitor that we use for treating HIV patients, and nirmatrelvir, which is another protease inhibitor that's specific to the COVID virus. So when used in combination, they are very good at reducing the risk of hospitalization and death. So if a patient gets the Pfizer drug within 5 days of symptom onset, it reduces the chance of hospitalization, severe disease, and death by almost 90%. And the amount of virus in the upper respiratory tract also has been noted to be decreased by this drug. So it's a very effective oral option we have. It is approved, or emergency use authorization has been given for patients 12 years or older. They have to be at least 88 pounds. It is very well tolerated. The typical symptoms that you can expect are a little bit of altered taste, muscle ache, diarrhea, and as you can see, some of the symptoms can be due to the virus itself. So the drug is very well tolerated. Pregnant and breastfeeding adults were not included in the study, but there are some data showing that it's safe in pregnancy and breastfeeding, but that has to be a very in-depth discussion with the healthcare provider to look at the risk and benefits. So Pfizer, it has to be given within 5 days of symptoms. Age is 12 years or older. Very good at reducing hospitalization and death. One thing to note is it can interact with some of the other drugs that patients might be taking, like heart arrhythmia drugs and blood thinners. So it has to be given in the healthcare provider who looks at all the drug-drug interactions and make sure it's safe for the patient. Next slide. In terms of IV options, one is IV sotrovimab. It is a monoclonal antibody. It is effective against Omicron, but it is not effective against the BA.2 variant. But there is a good news that there is a new monoclonal antibody called bebtelovimab, which is active against the BA.2 variant. So as the BA.2 variant keeps increasing in our community, we have switched from IV sotrovimab to the new monoclonal antibody drug that is effective against the new subvariant. The other IV options we have in the outpatient setting is IV remdesivir. It's an antiviral drug, which we have been using it from the beginning of the pandemic, mainly in the hospital setting. Now there is an option to give 3 days of IV daily infusion for high-risk patients in the infusion center. And this has shown to reduce hospitalization and death. It is also effective against the BA.2 subvariant that's kind of increasing in our community. Next slide. So the fourth option is another oral drug. It's called molnupiravir. It's a RNA polymerase inhibitor, and it reduces the chance of severe disease, death, or hospitalization by approximately 30%. So as you can see, it's not as effective as the Pfizer Paxlovid or the monoclonal antibody. So we use it as a option when the other drugs cannot be given to patients. It has been approved for emergency use authorization for patients 18 years or older, and it has to be given within 5 days of symptom onset. It is not given in children because it may affect bone and cartilage growth, and it is not recommended for people who are trying to conceive because there is toxicity involved. Next slide. Dr. Poland has given an extensive review of the BA2 subvariant. So I will just say a few points. It appears that it's more 30% transmissible than the initial Omicron, but so far it looks like it has the same severity as Omicron. We have seen that the number of hospitalization in UK has gone up, but the number of ICU patients or patients who need mechanical ventilation have not gone up. So that's a good positive signal so far that we are seeing. Vaccines appear to be good against the new subvariant in preventing severe disease, hospitalization, and death. So we have vaccines that are good. We have Paxlovid and molnupiravir and IV remdesivir as good options for this subvariant. Even though the old monoclonal antibody sotrovimab is not effective, we have a new monoclonal antibody that's available and in stock in Southwest Wisconsin that is available to patients. So that's all I have in terms of options for the Omicron in the outpatient setting, and I'm happy to answer any questions later. Thank you very much.
Well, I'd like to thank our outstanding presenters for those informative presentations, and we'll move over now to the question and answer session. Cindy, did you want to start with a question that you have, and otherwise I can tee one up for Dr. Poland?
Yeah, please, if you'd like to start.
Okay, so one of in the chat is the question about kids, the kiddos from age 6 months to 5 years. Tell us more about this Moderna vaccine, the efficacy that was reported, and now it looks like it has to go through the FDA, and what's the timeline on all of that?
Yeah, you're exactly right about that, Paul. What was reported today, these are high-level results, so don't have all the fine details, but Moderna did a phase 2, phase 3 trial called Kid Cove, and they looked at the group 6 months to less than 2, and then 2 to 5. Now, adults get 100 microgram dose in their primary series. These kids got 2 doses of 25 micrograms each, so a quarter of the dose of adults. Well tolerated. They didn't see any evidence of myocarditis. Fever was lower than in adults, but the efficacy against infection was about 40%. It was actually 44% for the younger kids and 38% for the older kids. So they did not have any severe cases, but that's a power issue in that you don't tend to see a lot of severe cases in kids that young.
So encouraging news. From a health system standpoint, if there is approval for emergency, et cetera, we generally are on top of that, and we let our patients and affected patients know.
Yeah.
Dr. Raj, just to reiterate, with the new subvariant coming through, we have treatment available, including the new monoclonal antibody. How will we know that? Are you just presuming patients have that subvariant and treating them that way?
Uh, uh, so we get the information from the CDC and the national surveillance. They use genomic surveillance to see which variant is going up. If you look at the COVID CDC data tracking tool, you can actually see in different communities what proportion of the viruses is due to the subvariant and how it's going up, trending up. So we use those informations to kind of decide when to transition from one monoclonal antibody to the other. So as of this week, uh, in the Midwest, Mayo Clinic's health system sites, we have transitioned from the old sotrovimab to the new monoclonal antibody that is active against the subvariant.
So that's good news, is that we're prepared, we're ready if an infection occurs. How do you decide who gets that treatment?
Very good question. So right from the beginning of the pandemic, the Midwest COVID treatment group, it's a enterprise level or the Midwest level panel within the Mayo Health System that kind of determine which patients are high risk. They use the data available from the CDC, NHS guidelines to determine which patients are at higher risk for severe disease progression. And those patients who test positive in the Mayo Clinic Health System sites will be called by one of our nurses to kind of go through the risk and benefits of the monoclonal antibody and the other options available. And when the patient agrees and gives consent, they will be brought into one of our infusion center to get the monoclonal antibody.
So I can attest, as a physician who cares for patients in the region, if one of my patients tests positive, I'm almost out of the loop because this team actually does it all on our patients' behalf, because of course we want to treat people right away. So it's really a wonderful service. And then Caroline, I have a question for you. You mentioned healthcare workers and providers, and the stress is high. There's a lot in the media about burnout and working hard and caring for patients, and really more. And over the last 6 to 9 months, patients hospitalized with COVID who say they don't have it, and they're demanding certain treatments and so on. And it can be testy and hard on our workers. It seems to me and that you have patients who have COVID and they're affected by that. Then you have the caregivers who are affected by that. And then you have people who have had both. What are you seeing, sort of a spectrum of severity based on a number of risk factors and so on, or help me understand that more?
So when we look at things like secondary traumatic stress, one of the aspects that goes into that are prior experiences of trauma that that individual has experienced. That can either be a positive or a negative. If we have actually gone through treatment and addressed our historical experiences of trauma, that can serve as a protective barrier. And if we haven't addressed it, then this just piles on top of that. And because trauma changes our brain chemistry, our brain chemicals, our nervous system, we're familiar with the fight, flight, or freeze survival instincts, that actually impacts not only rates of burnout and secondary traumatic stress, but also our overall mental health and well-being.
Great.
So,
Cindy. Oh, go ahead.
So really being proactive, like I said, and reactive about addressing our experiences is part of post-traumatic growth and laying a good foundation for the next difficult thing or traumatic thing that we experience.
From a health system standpoint, we try to implement proactive screening of our patients who might be struggling in this area. So not only social determinants of health, but depression, anxiety, and so on. Cindy, other questions?
Yeah, so a question that we're seeing a lot and was submitted beforehand is about natural immunity. People are wondering, is is natural immunity a thing? Can they improve it? Should they be getting the vaccine if they've already been exposed to COVID-19? So curious your thoughts on that.
Yeah, that term natural immunity gets used a few ways. Getting infected with a virus is not natural immunity. That is illness-induced immunity. Let's be very clear about that, because there's a tendency to kind of glamorize the idea of, quote, natural. Sounds good. No, we don't want people getting infected because of the short-term and the considerable long-term consequences of that. Prior infection does not lead to long-term immunity, and that's why even after infection, we immunize individuals, or at least we attempt to, and we recommend it to them. Now, the other way in which natural immunity sometimes gets used is sort of to say, well, what about our own inborn immunity, our innate immunity, the health of our immune system? And that very much is structured actually over the paradigm that my daughter listed there. Proper sleep, proper nutrition, proper exercise not only prevents comorbidities, but keeps our immune systems as strong as possible. By the way, just today, Mayo Clinic Press released a very nice 5, 6, 7-page brochure on healthy immune systems, written by one of our colleagues, Dr. Stephen Kopecki. And I've glanced through it. I thought it was very well done and commend it to you.
Along those lines, and just in follow-up then, it's going to be the question we hear all the time. So you have your first series of 2, then you get your booster. For certain people, another booster is recommended, but will there be a general recommendation for us to get the second booster, or is this going to be a yearly thing, or how does that work?
Yeah, I wish I knew. April 6th, the FDA Advisory Committee, I was a former member of it, is going to get together to discuss the notion of continuing boosters. And it's again, welcome to the matrix. It's a very difficult thing to predict. If I had to speculate, I think that if BA2 continues the direction that it is, we probably will allow boosters in people who have certain comorbidities and who are, say, 65 and older. Some countries have chosen 80 and older. If we have a new variant or a surge this summer, fall, like we've had the last 2 years, then I think we'll see a more general recommendation for boosters in all eligible populations. But right now, it's so hard to speculate, and it goes back to the distorting effects of human behavior by eliminating masks and pretending the pandemic is over. That's almost a guarantee of seeing new infections, which leads to new variants, which can lead, depending on the variant, to increased transmission, increased illness. So we kind of, in my opinion, we declared victory too soon and too aggressively as a nation, started decreasing non-pharmaceutical interventions like masking.
So I'll follow up on that with both you, Greg, and Raj. That CDC map that I showed, again, just from a few days ago, all that data that I presented, it's green for most of the country. And if you look at the site, it says masking is more or less elective.
Yeah.
Do you agree with that, or tell us more about that? Certainly not in our hospitals.
Yeah, it drives me crazy. Imagine I talked about let's pretend that I mentioned today that I announced a new virus that had a 30, 40, maybe as low as 25% chance of causing long-term symptoms that would decrease the quality of your life, that led to a substantial increase in over 20 cardiovascular diseases and diabetes over the next year, and said, you know what, don't worry about it. It's only 1,000 people a day who are dying of it. You'd say, what kind, was this guy, is he informed or not? Like I say, if it was 1,000 polio cases a day, it would be absolute pandemonium. But this has become normalized in a way that people are emotionally exhausted, and that's what's driving this rather than the science itself.
Okay, so now we have a setup here of human behaviors. It's been clear. The virus is going to circulate in our communities. There are going to be variants. It mutates a lot. Dr. Palraj, the oral drugs, the Pfizer drug, let's say, can I just write a prescription for that right now, or is it in good supply? Are there others on the horizon that we'll be able to prescribe, sort of like the Tamiflu for COVID?
I think Paxlovid has the more promising result or effectiveness against this virus compared to the other oral drug. And the stocks are good, but I believe if we have a huge surge, I don't think there will be enough availability of the Paxlovid. So that's why non-pharmacological intervention prevention is more important than having more supplies of Paxlovid.
Right.
And right now, if you have a positive test, then you can get prescription for Paxlovid.
And we have it in good supply, you said.
Yeah.
Okay, Cindy. other
Yeah.
question?
Yeah, so I know we have a lot of people from different school districts in attendance today. So if you could, Caroline, maybe address, that kids are having increased anxiety, depression, behavioral issues the last few years. Do you have any tips or resources to help with school-age children, specifically elementary or school age?
Sure. Well, this is such a significant issue, and really it was even prior to this pandemic, right? This has just put a spotlight on an already existing set of circumstances. If you go to my YouTube channel, again, Poland and Associates Consulting, I have a whole playlist on educator-specific videos. Part of what my business does is trauma-informed care in educational and hospital settings. So I have some videos on that. Again, if you reach out to me, I'm happy to have further conversation with you on that topic. But a couple things to remember: our nervous systems are made to regulate and co-regulate off of one another. And so if me as the people helper, counselor, educator is dysregulated, if I'm in fight or flight outside of my window of tolerance, again, that zone or range where I can optimally function, then a patient sitting across from me, a student in the classroom, is more likely to become dysregulated too. So I think that highlights for any of us who are people helpers or educators, again, this increased need to do our own work to make sure that we are able to emotionally regulate so that we can be this good foundation so our students or patients can regulate their nervous systems off of us. And then the other thing that I would say is to just be proactive in classroom settings. Don't wait until you see a student becoming dysregulated, but intentionally at whatever interval you feel is best for your students, kind of stop the flow or in between subjects and just put in a little emotional regulation exercise. That way, if students are in shutdown and dissociated, so you're not seeing the anger or anxiety symptoms, you're still catching them and bringing them back into their window of tolerance instead. So the more we can be proactive about incorporating these emotional regulation skills and trauma-informed care into classrooms, the better foundation overall we're creating.
Mm-hmm. So we have another question here about the wearing of masks in schools for those who are fully vaccinated, and then even looking at this summer as people start going outside. Do people still need to be concerned about being around unvaccinated people? So if you guys could work on answering that.
If we could develop some public health policy. Raj, this will be a good conversation. I'll throw out something and then you can enlarge on it. I'll tell you my personal practice, though I'm triply vaccinated, I would not go into indoor settings absent wearing a proper mask properly. My own opinion is that would be foolish to do. It's neither good for me nor good for other people. And as physicians and healthcare providers, we serve as role models. Caroline was talking about that regulation off one another. If you see healthcare providers that you trust wearing masks, you're going to ask yourself, what do they know that I don't know? Maybe I ought to be doing that. Outdoors, where you're not in a highly crowded situation, I don't wear a mask, and I think that the levels are low enough that it doesn't warrant wearing a mask. Now, if you're moderately to severely immunocompromised or in some other way high risk, that of course is a different story. Raj, what would you add to that?
I completely agree with your advice. I will do exactly the same thing. I am triple vaccinated, but if I go to an indoor setting, I would still wear a properly fitted mask to protect myself as well as others, as the vaccines are not 100% in protecting mild infections. And we know that mild infections can still have long-term consequences. So I would still protect myself, especially with the new highly transmissible subvariants. It's better to be safe.
Raj, I'm glad you mentioned that. Can I just throw in quickly, because people think, oh, I had a mild infection, I got over it quickly. That might be the case, but somewhere around 25 to as high as 50% of those individuals end up with a symptom that lasts 12 weeks or longer. An excellent study showing about a 40% increase in hyperglycemia and diabetes. Another study showing evidence of shrinking of neuronal cells. And we wonder whether we're going to see premature neurodegenerative disorders in people who got infected. I mentioned it earlier, an elegant study. I mean, this thing was huge to do, documenting an increased risk of 20 different cardiovascular disease for as long as a year after infection. Mental health diagnoses, mental health admissions to the hospital, all increasing, even with mild COVID infections. So do not be deceived into thinking this is like influenza and I'm going to have a mild infection and that's that. Maybe, but you don't get to pick.
Yeah, and so naturally people who are triple vaccinated, like we all are, and potentially a fourth coming down the pike, and you're seeing very low community spread, a reasonable person might assess that and say, I think I'm going to be okay here, but I think ongoing vigilance and monitoring of the local situation is really important. And
Yeah,
that's and it's you have to strike a balance there on that. And along those lines, Mayo Clinic in Midwest is at our sites is easing visitor restrictions.
yeah.
I don't know if any of you want to comment on that, but we're allowing more visitors. But the fact is that in our sites, you still have to mask and socially distance, which kind of makes sense because if you're going to pick a place where there's a reservoir of COVID, it's probably in hospitals. So we're still very careful. When I see Dr. Paul Raj, I only see him with a mask and goggles on, and same for me when he sees me, not in person. So,
but I think that policy is appropriate, Paul. We're at a stage where, and there are a lot of good mental health and physiologic reasons why hospitalized patients should have visitors. The
Right.
issue is not curtailing what we do, it's doing it in a safe way, as you're pointing out. But looking forward, I have concerns, and this is part of my job, is when you look at increase of highly transmissible variant, when you look at a flood of refugees going into
Right.
Western Europe and then into the US, when you look at waning immunity, when you look at the announcement the White House made last night that they do not have the money to purchase a booster dose for every American, They only have money for people under the age of 5 and over the age of 65. You put all those factors together, and if a new variant were to take off, we would be in a very bad way.
Thank you. So in wrapping up, and I'll turn it over to Cindy here shortly, the message is very similar. Get vaccinated. If you need a booster, get a booster. Watch carefully the news channels for the 4th. Watch for the kiddos 6 months to 5 years. We have treatment if you get infected. If you get symptoms that are of concern, get tested. Be very careful about the masking, certainly indoors. One way to monitor that is the community spread, and public health sites have that. If you're concerned, err on the side of being conservative and wear a mask. Outdoors, you're probably okay.
And I would add to that, Paul, lest anybody misunderstand, the news is good here.
Yeah.
Case rates are way, way down. The issue that I think all of us are promoting is let's keep it that way.
Yeah.
By getting our boosters, by wearing our masks.
Thank you. Cindy, any further comments?
I just want to thank our panelists today for sharing their time and their expertise. I also want to thank our attendees for joining us and the media who have joined us and are going to help share information from today's event. Zoom registrants will receive a follow-up email with a link to a recording of this presentation. We also plan to post it to our Mayo Clinic Health System YouTube page. And then if we can have the last slide up on the screen, there is an email address on it, and folks can email that if you would like a recording of today's presentation, or if you have feedback you'd like to share with us. So this concludes today's program. Thank you all, and have a wonderful afternoon.
Thank you.
Thanks.